lunch and learn session for us. So Alice is a GP, emergency physician. She's also president of, or she, I'll probably get the title wrong, President Digital for the Royal Medical.
President-elect for the Royal Society of Medicine Digital Health Section.
That's the one. It'll be easier if I just let you introduce yourself, Alice. So this session is being recorded and it will be shared on the Members Hub, so you can catch up on the recording if you missed anything, and you can, direct your other member friends that may have missed the session. So I think we shall now pass over to Alice and I will mute myself. Alice, over to you.
Thank you very much. And I'd just like to say thank you very much for this opportunity to speak about this subject, and also for everybody who's turned up and shown an interest in this. We received the list of questions and points that people were interested in, and hopefully most of what was asked in the pre-session information will have been answered. But if not, we'll definitely have a session at the end, a bit at the end for a Q&A. So as was just been explained, my background is emergency medicine and a GP, both in the UK and in Spain, where I worked with Gypsy and Roma and Traveller community members. And I've worked on and off with friends, families and travellers for the past 15 years. Throughout my career, which has gone from clinical to digital health, and has also included in consulting on electronic health records and making them valid in a clinical setting, etc. So let me just explain a bit more about who friends, families and travellers are, and also pass on the apologies of Michelle Gavin, who is the community member who would have been able to give more community insights, which again I hope we've answered. She helped me last night and I hope we've answered most of them, but we're very happy to take questions and take them offline if I can't answer them as well. So Friends, Families and Travellers is a national charity to represent Gypsy, Roma and Traveller people, and we are active in advocacy, casework, policy and cultural competency training. So the people who FFT support are the Gypsy, Roma and Traveller communities, who make up 1 in 200 of our current population in the UK. So traditionally people associate these communities with a nomadic lifestyle, which is still true for some, but 74% are now living in bricks and mortar. The Gypsy, Roma and Traveller term is actually an umbrella term, and if you look on this slide you can see how many different ethnicities and groups that are covered by this. So Romani Gypsies, New Travellers, Slovak, Roma, etc., etc. So in 2011, Baroness Vasi suggested that Islamophobia had passed the dinner table test and is now socially acceptable. This was based on information that, on a report, the Muslims are the UK's second least liked group. The question now remains, where does that leave Gypsies and Irish travellers and Roma, who come number 1 as the least liked group? In fact, the Equality and Human Rights Commission did actually point out that now the hostility towards Gypsies and travellers is common, frequently overt and seen as justified, and Friends, Families and Travellers, FFT, have challenged certain media portrayals in famous Amazon Prime episodes, which you can look up in Google. So for the health context, in 2020, a report found there was a 7.1 year difference at birth between Irish traveller, Romani Gypsy women and the general female population. And this goes up to a 10.3 year difference for men. Additionally, the years the years up to the death are complicated by chronic diseases and general ill health. Now, what you'll see here is that these are non-NHS data. It's from an EU Agency for Fundamental Rights. And this is why we're here today. One of the greatest challenges that we have is that we don't have data, specifically in the NHS. And this is due to the fact that Gypsy, Roma and travellers and other communities are not included in the NHS data dictionary, which still uses the 2001 census categories. What we do know about health outcomes is that 1 in 15 families suffer the death of a child, compared with 1 in 100 in the general population. 42% are living with long-term conditions, compared with 18% in the general population. Another issue is that the health of a 60-year-old Romani or traveller is similar to that of an 80-year-old white British person. And I'm sure some of you will have worked on the Rockwood Clinical Frailty Score, which has been integrated into electronic health records, but which is actually only validated in over 65s. This often leads to failure of services in those who are frail before their time, Gypsy, Roma, traveller, people who are living on the streets, etc. So the other issue is that and this is specifically in answer to one of the questions that came up in the pre-session preparation, was a question about mental health and ethnicity. So Gypsy, Roma and traveller are 6 times more likely to die by suicide, which goes up to 7 times if male. This is likely to be massively underestimated for 2 reasons. One, as mentioned, because there's a lack of ability to code, but also 2, and one that's probably a bit harder to overcome, is that if you're not going to your GP and you're not talking about mental health, when you die by suicide, it may just be written as an accident. So when it comes to talking about mental health in this community, there is still a lot of stigma, which leads to people not going to the GP. So one of the questions was about how do you talk about mental health? So the recommendation is to talk about nerves rather than mental health, to ask about how are your nerves, and when it comes to to identify and encoding, to instead of specifically asking for a code, ask people more generally, how would you identify? Leave an open door question. Ask, which community do you identify with? This might still actually be too complicated. And another workaround that we have is to get the list from the NHS data dictionary and go down it and said, well, would you identify with this community? Would you identify with this community? The important point being that the level of health literacy and literacy is very low. And so it's always really, really important to read these terms out. People quite often come across as not having any literacy issues and can be embarrassed to say that they can't read or write. So again, another top tip is to actually just start reading it and explain it. So another question that came up was about finding these people, as they have been excluded from traditional data sets. As mentioned, one of the big issues is that they're not in an NHS data dictionary. And, this is not just Gypsies, Roma and travellers. Arabs too can't be categorised at the moment. So what have we done historically to interpret data from missing populations? We've used workarounds from non-NHS sources, such as the Department of Work and Pensions, Department of Education, localised public health data, small-scale academic reports. However, the issue is quite often is that you don't know what you don't know. So if you're not even aware of the ethnicity that you're missing, you're not going to look for them, obviously. So again, going back to this point about the NHS data dictionary, it is currently only in England that you're unable to categorise Gypsy, Roma and travellers. in Public Health Scotland and NHS Wales do. So for a long time, we've been campaigning to be able to have the 2021 census categories in the NHS data dictionary, although this is just a subset and still not where we need to be. And I'm very happy to include as an update in this session from the last time I spoke at the CDAO conference back earlier this year, that we have progress. So we have some interim guidance from NHSE. They are working with other agencies and departments, but we do have interim doing guidance, which I think is particularly relevant to the people on this call. So the important bit of here is if the design of a new project cannot wait until the joint DHSC and NHSE-led standards are published, it should make use of the latest ethnicity standard, which is the Census 2021 ethnicity codes. These new guidance should be coming out towards the end of the year. So most new projects will probably be able to wait. But the second most important point is that the ethnicity groups which are defined in the 2011 and 2021 census will be mappable to any new standards developed. This is a major breakthrough for Gypsy, Roma and Traveller and all the other ethnicities who have been left to one side. So from what are the coding consequences? So we found that 1 in 10 have missing ethnicity records, and that's either because they're not being collected, sometimes because people prefer not to say. And of the records that do have codes, PPI work has led us to realize that people sometimes are inferring patient ethnicity. And when we think about the bias towards these communities, sometimes this can be wrong, and of course, it can lead to racial profiling. As a very clear example of the consequences, if you look at the NHS data, the records state that no person of Gypsy, Roma, and Traveller ethnicity died of COVID. Whereas we know from the earlier slides that this population have the worst health outcomes, and of course COVID will have affected them as more than anyone else. So we've spoken briefly about this. You can't commission for what you don't know. This is why it's so important. You can't go and do cultural competency in a hospital that does not even recognise that it might have a Gypsy Traveller community. You can't make a change until you prove the need, and that includes getting the funding. Another question that came up was about inclusion health groups and population health management. So if we look at that, population health management looks to understand the health needs of a specific population and then looks at working on the health outcomes. We can understand why the coding is so important, and this is one of the reasons we've pushed. But it's also moving away from the reactive healthcare to proactive healthcare. Again, with the big move in the NHS, again towards more community and more towards prevention. Again, this is a point that particularly touches this community due to the fact of their high comorbidities, their early comorbidities, which are quite often left out of screening or programs to catch them and intervene at an earlier stage. So, although we're talking about Gypsy, Roma, and Traveller here, they are one of the inclusion health groups. Sorry. As mentioned before, people who experience homelessness, drug and alcohol dependence, might have earlier frailty, vulnerable migrants, sex workers, people in contact with the justice system, and victims of modern slavery are all part of the inclusion health groups who need extra support to be able to access healthcare, and who are with worse health outcomes. So the future is digital. Everyone's talking about AI, and the fact is that this is also a time where people are worried because of it's a time of opportunity, but it's also a time that we can potentially worsen existing biases with clinical prediction models. I'm sure many of you have been involved in creating and thinking about. There are people talking about this, and some people, we don't work with them, but the Ethnicity, Equity and AI project at Oxford University are a group, for example, who've been working on this. Another question that came up was talking about recording ethnicity sensitively and outcomes sensitively. For example, if you're recording sexuality in a country where homosexuality is illegal, that can obviously have consequences. With if we're looking at reporting KPIs sensitively, so their DNA rates or length of stay, the recommendation is that we would always want to have this data reported with a wider context, not just report the DNA, not just report the length of stay, but include in all the relevant information about the challenges which may lead to these. And again, this is something that you have access to and can include in any reports that you're asked to generate. So another question which came in the pre-meeting information was asking about statistical values and calculations, statistical techniques and accessible visualizations for non-analysts and standardizations and working with small cohorts. And I just have to say at this point, I have to hand over to you because this is not something I can answer. And but we would be very happy to speak to people whoever asked the question, but also generally to maybe at the end find some solutions to that between all of us. So again, this is from the Oxford group. They have been working, we can see all of the, so it's not just the NHS data dictionary, they work with the research codes. Many people who work in the research will be coming to you asking for data, and the research codes, and so if we look at the SNOMED codes, 489 codes, which are then brought down to only 19 in NHS codes, which are then brought down to only 6 in research codes. There's a real opportunity there for when data is handed over to educate, to explain that there is there are more categories available, and to make people stop and think. So now we're going to talk about a couple of case studies. Well, the first one is actually just a short sort of picture of a very simple problem, but one that affects people and why they often get dropped off. So one of the workarounds that people have done to try and identify Gypsy and Roma and traveller populations at local levels has been looking at specific postcodes where there is a higher group of Gypsy, Roma and traveller. However, even working with postcodes doesn't work, because if people are nomadic, their postcode will change. And that is due to the fact that there are not enough legal sites for people to stay in the same place. Again, this is not just an issue with Gypsy, Roma and travellers. This is people who are homeless, people who are migrants, people who are trafficked, people who are sex workers, and along, etc. A very specific example relevant to the Irish traveller community is galactosemia, and why being able to code people as Irish travellers is important. So we have a case, it's an anonymised case study brought together with several, with experiences of several families. So Margaret is a mother of 3 and pregnant for the 4th time. She is eager to welcome a new baby in her family. She's been travelling with her husband and 2 children across the UK from Ireland. They live a highly nomadic lifestyle. She struggled to register with a GP because she does not have a fixed address. And she's not being able to disclose to healthcare providers that she's an Irish traveller, and none of her health records since she's travelled in England mention her ethnicity. She starts giving birth on the side of the road. They call an ambulance and are taken to the hospital. The birth went well, and both mum and baby seem healthy. They leave and are excited for their adventure as parents with their newborn and a new addition to the family. However, they were not able to provide an address for a midwife to visit them in a few days' time for a heel prick test. The parents start to struggle as their newborn refuses to eat and appears to have a lot of discomfort. They think the baby is allergic to milk, but actually the baby has classic galactosemia. They become more worried and go to the nearest A&E. It takes a lot of time for the health professionals to ascertain what's happening, and by the time they've diagnosed the newborn, it is too late to give them treatment. Due to the delay, the infant had no chance of surviving and dies within his first week of life. The parents are distraught. Classical galactosemia, although extremely rare among the general population, affects 1 out of 450 Irish traveller newborns. If the mother had been able to disclose her ethnicity, maybe health providers, given they had received cultural or specific training, would have immediately advocated for the child to receive a Boytless test at birth. In NHS England, this is not a requirement. However, in Ireland, health providers are obliged to give a Boytless test at birth to infants born to Irish travellers' parents. And if caught early enough, the infant can survive. There was no follow-up on how the family was doing, as it was assumed they would be on the road. They had also not been made aware that they were entitled to specialist on-site support because of their Gypsy Roma traveller status. This lack of support also impacted the younger children who were attending school, where they were given no support to help them deal with their bereavement. The eldest behaviour disintegrated and started attending school only partially because of this traumatic loss and lack of support. And the whole family lived through this loss very vividly. A few years later, the mother fell pregnant and presented to health services earlier due to her past trauma. But she was unable to explain what happened to her previous pregnancy, but she was only given leaflets she could not read, and no one had explained to her what happened. She told her medical team that they were Irish traveller. Due to the confusion, the unborn child was put on the at-risk list, which prompted a lot of anger, which was again misinterpreted. Out of fear of what would happen, the mother delayed her arrival at the hospital to give birth and left as soon as possible. Fortunately, in an MDT, a specialist midwife was present and saw in her written notes her ethnicity. Again, not written notes and not coded. She was able to get resources to do a site visit, and this midwife, who had cultural training, was able to support and report in a loving and well cared for setting. She was also able to assess the circumstances appropriately thanks to the cultural training, and this led to rebuilding some of the trust that the family had completely lost. So, as I said, this is anonymized, but very much based on stories that we were told, including the being put on the at-risk register when asking for help. So this leads to the next point, which is why it's not that simple. And we need to think about trust, standardization, and real life. So just because we can doesn't mean that we should. And it's something that we need to think about. So the genocide of over 500,000 Gypsy people during the Holocaust is still relatively unknown outside of the community, but does lead to people having fears about being put on a list, especially with what's happening in the world at the moment. There are fears about ambulances not coming if they declare their ethnicity or even their postcode. Certain traveller sites are blocklisted by car insurance companies, by phone and internet providers. And within the Roma community, the fear originates from their countries of origin, where it wasn't unusual for Roma people to be openly discriminated against and segregated. So therefore, quite often, Roma people will not disclose their ethnicity, and if they say anything, they'll say they are Polish, Romanian, or Slovak. However, FFT have done some work on this for the NHS England secure data environment, and we came to the concluded that the following points: that Gypsy, Roma, and traveller people are happy to share data and coding and ethnicity when correctly informed with GPs, with academics, for the good of their respective community. And this came up time and time again in a community where the community bonds are so strong. If asked to do something because it will help other people, even if not close family, people are very keen to help. And specifically in the context of health data. So when Gypsy travellers were added to the 2011 census, 63,000 people shared their ethnicity, and this doubled again in the 2021 census. There are concerns about sharing ethnicity with housing groups, but in the health context, people are happy to share their ethnicity. So the potential counter argument that there are trust issues, that even if you can, people won't, is not a compelling argument. I mean, there are no data, and if the NHS is to understand the needs of its patient, the government should ensure it's capturing the ethnicity in as much detail as possible. Avoiding a potential solution just because it's imperfect helps nobody. So now we come to the point, so what can we do together? So FFT work at a national level. We've got caseworkers, and across the country, we've got support teams across the country. We can educate clinicians, we can support data and analytical officers, and we're very happy. We've got the contact details will be at the end. We're very happy for you to reach out to us and to have one-on-one calls or with specific points if you're interested or if you need it. Another point we've been asking for is asking for the NHS app to be changed so that people can self-report their ethnicity. This is a work in progress, but hopefully when, not if, this happens, FFT will be able to galvanize the community to start self-reporting and therefore collect data a lot quicker. So specifically for the people in this audience, I thought the most relevant points are that no matter when this new guidance comes out, it's clear that the 2011 and 2021 census categories are going to be mappable to any standards. So the way forward is to start working with these new categories, start talking about them, start integrating them into your planning. Quite often I find it's not through lack of wanting to help, it's just that people are unaware. So the more conversations we can have at early planning stages, at all levels, whether it's designing the IT all the way through to the clinical pathway, to how it's going to be cascaded out and the annual mandatory training, for example. These are all moments that we can start talking about these different census categories, these opportunities, and also educate people. Collaborating, as mentioned before, on research projects raises the profile of and the role of data analysts, as well as making sure that research is not limited by not using the right ethnicity categories. So that's me. I've rattled on for a bit. I hope I've answered most of the questions, but I'd be really keen to open now to hear people's opinions, thoughts, questions, solutions, experiences, because I'm sure many people will have had their own experiences already. Thank you very much.
Thank you, Alice. That was yeah, really, really insightful. In this day and age, you just think you've got it together with the data. We collect so much data, yet there's still so much missing out there. What you suggested as well about maybe collaborating with somebody, if there was any volunteers in our audience who wanted to work with Alice to look about different approaches to how to do, the statistical approaches. I think you mentioned one of the questions. Then by all means, put your name forward and we can get you in touch and give you a little project there to work on. So I'm just watching the chat. I can't see any questions there. Are there any additional questions from anyone? If you can raise your hands if you want to just ask rather than type things in the chat. Joe. Joe
Hello.
Johnson. Hello.
Yeah, I guess I'm not sure that this is a question, but I found this really, really interesting because when we're looking at our data from a PHM point of view, we know that we have maybe lots isn't the right word, but we have a Gypsy, Roma and Traveller community within our patch, but we can't identify anything about them. And we've been struggling with this for a long time. So it's been really exciting to watch your presentation. And yeah, we're looking forward to what we can do next with these new categories when they arrive.
Yes, no, I'm that's exactly it. So it's absolutely the point is that we're all in, the tools haven't been there, but now the recommendations are coming out. So we're obviously pushing these recommendations as much as possible because now now's the time to do it, basically.
Is there anything that we can do to lobby to get them implemented or?
Oh, yes, please.
Yeah.
And I think that's maybe something that maybe with Jane we can have a think about how best to use your community members to lobby. Things obviously is changing quickly with NHS England because that was the guidance that had come out with from NHS England, and that's moving over. So I think, I mean, we can look at a campaign, but also even just constantly asking, so it doesn't get forgotten, because I think a lot of this is actually just keep reminding people, wait a minute, why when are these new recommendations coming out? Why we want to design, so the recommendation is not until is to wait for the new categories to use these, to wait for the new categories, which will basically be the same, at least as regards for Gypsy, Roma and Traveller. So I think just starting to incorporate it into daily work, because it is a question of time. It is a question of time.
Cool.
Maybe we can, if we have a couple of volunteers, people like you, Joe, anyone else on the call that maybe wants to put their name forward, we can just get a separate meeting together to discuss something.
Yeah, that would be awesome.
Where
I've
we
got
can go. Just a small group.
Yeah, I have a colleague who's on leave this week, but he'd absolutely be into this 100%. So yeah, there's definitely people who are interested.
Right, I'm just going to put my email address. There's so many A's. AphA list.org. Right, so my email
Aardvark
address is in the
Analytics.
chat. So anybody that is interested in maybe just getting together a small discussion group, then drop me a line. Oh, and Alice has given hers there as well. So yeah, drop a line to both of us and maybe we can pull together some sort of small discussion group. We are looking to launch another special interest group, another network within AphA, which will be the Research Liaison Network. So it might be good once that comes up, maybe we can link in with them to go back to some of those other, other wider questions. just looking at the chat as well, Rachel has said, not a question, but just say thanks for sharing it. It's the stories that bring this to life. But as you say, it's not in the data. I've just got a question on SNOMED, because I know SNOMED I've worked mostly in acute, and it's all ICD-10, APCS and everything else. SNOMED is used a lot more maybe in primary care. I suppose maybe going back to Joe or anyone else that deals with population health management that uses primary care data in their linking up their records to get that longitudinal pathway, are they able to maybe identify easier from SNOMED that we can't do from the main coding? Is there anything that's recorded in primary care that maybe helps out with some of this? I don't know if anyone's got any experience or comments on that. Oh dear. No, but yes, as you say, for population health, it's all about looking at inequalities as well and directing resource where it's absolutely needed. And how can we direct it if we can't even identify that that's where it needs to be directed to? It's a real dilemma, isn't it? Because it's just not helping with those equity of care situations. So any further questions or comments from anyone?
I'd just like to say also for us, it's really important to be able to work with you, because we can only do so much from our side, but you're the people who'll be helping roll it out and have the insights and can flag up the issues. So we're very, very keen to work with people.
Yeah, so we just need all those volunteers from you guys. And actually, we could probably put it in a newsletter or in a magazine or something as well, looking for volunteers just to set up a small discussion group about, how we can work together, how we can help with things. Any idea when they might be releasing the
yesterday 2026, who knows? It's something about towards the end of the year, so
we'll have another of these sessions then.
I think there's an argument, if it's taking too long, that even just ongoing design has to be changed, would be my personal perspective, because can only wait so long.
Rachel, again, from Strategy Unit, said she'll ask the Midlands Analyst Network and others. Maybe you could do a session for the Midland Analyst Network, Rachel. You've got Alice's email there now in the chat if you wanted to get in touch with her directly to arrange maybe for one of your sessions, and then you might find some more volunteers pop up from that.
I'd be interested to hear if there are any other groups that people are struggling to find for different reason, maybe not necessarily NHS data dictionary census categories. I don't know if people have come across other groups that we could collaborate more with.
That's
interesting. Yes, and have quite often also, and even yes, no, that's a very good one actually. Have you got any specific contacts or thoughts as to who we could contact there?
No, not yet. I think my colleague Chris, he's our PHM lead, so he might have more ideas than I do. But I think we've just reached a lot of dead ends, because it's not because the records are handed over from the military to more NHS world. I'm not quite sure the right terminologies, but there's nothing to say that's happened. So we just can't see them in our data. They just look like everyone else. And there's the armed forces card, but I don't think that there is a code to say that someone has a veterans card. So for us, the presence of a veterans card isn't useful. But even if we could get access to a database where we knew who holds the veterans cards, that would be helpful.
I've actually a colleague that I used to work with at Surrey Heartlands, who worked in the PHM with me. He was ex-military, and he's now gone back into supporting military organisations. So it might be good to have a chat with him, because obviously ex-forces, there's a lot of mental health issues.
Yeah.
So yeah, I might see if I can get in touch with him and see if there's any suggestions.
There is also a crossover that we've tried to sort of mention, in that quite often the issue is also with the continuity of care. Secondary care, for example, when people move around, so dropping off waiting lists as you know, for referrals or whatever. And someone did mention that the armed forces did have ways round that. But that's definitely another issue as well. Is that so the late presentation, for example, lung cancer or whatever, they're missed off screenings, they've got low health expectations, so they sort of normalize feeling unwell. And then if there is a referral made, then if they've moved from one ICB to another, that potentially they just get dropped off and have to start all over at the bottom of the queue again. So I think the armed forces have probably got parallels there.
Yeah, Rachel's again suggested the Health and Care Analytics Conference. So those of you on the call, AphA Health and Care Analytics Conference, which has been a face-to-face for the last 2 years. This year, obviously, because of funding cuts, it's going to be turning into a virtual. It'll still be a 2-day session. So there might be opportunity to bring you into that conference and access to a wider, network of analysts through that as well.
And hopefully by that point, we'd have the updated recommendations as well.
Yes, yeah, I think it's 3rd and 4th of December, something like that. It's early December anyway. Another two, oh, Joe, you're full of ideas today. Children in the justice system and children in care. The council holds the records for the children, but there's no common identifiers between their data, ours and ours, other than names we can fuzzy match on. But there's no appetite to do anything that isn't accurate. So again, Surrey Heartlands, we did link in our social care data to the rest of our health data. We linked it in because we had quite good 85% coverage of NHS numbers. So we were able to do quite a good bit of linking of social care. And we had a flag for children that were on a register for children that were, in
at risk.
Yeah, at risk, that's the one. So again, so it might be a case of, in the whole PHM data sharing agreements, trying to bring some of those things in, and yeah, pushing for that NHS number. But I understand that some, might only have 50%, and if you're doing fuzzy matching, it's not always great, although it might, better than nothing. But yes, that's another area that needs to just be addressed across the whole data sharing of systems. Rachel, I saw your face pop up and then disappear there. Were you going to say something?
No, you just mentioned hacker, and I just thought, he just needed to see me.
Yeah,
No,
Alice,
absolutely not.
Rachel, Alice.
No, it's these are. I just find these sort of enduring sort of problems there that are fascinating. I think back to sort of being involved with doing a needs assessment. I'm talking about 10, 15 years ago for this community. It was even longer than that, I know it was. And I think the only way we could get to having some really good information about this group, and this would have been in Staffordshire, so not necessarily an area that you would associate with these communities, but people don't know. You really don't know, because they are so hidden. And it was a very much a qual assessment of the situation. So there were interviews with people, so we really got under the bonnet of everything, and we understood, like you've sort of described, some of these like personal stories, and I think these are the things that really bring it to life and really sort of highlight the real need and problems that people have got, and not just the sort of superficial, there isn't a code for that kind of thing. It's much deeper than that. But yeah, so thank you ever so much for sharing that. It's really got me interested in something that I'm not supposed to be interested in at the moment. I'm supposed to be concentrating on something entirely different. so
I'll take that as a great compliment.
Oh, absolutely! I've gone off a tangent, and I'm looking at all this stuff, and I'm thinking this is fascinating, and it affects a lot more people than people.
1 in 200.
Yeah, that is so many. That's a lot, isn't it?
Yeah. Would you be able to share? I mean, I know you said it was a long time ago. Would you have that information still, or because that would be great?
Shall I distract myself even further and try and dig it out? I'm up for it, Alice. I'm up for it.
That would be great. It'd be really interesting. Yeah, please.
I will try and find it.
Excellent. Right. Any more questions or comments there? No. Okay, then. Well, we've got a little bit of time to go. Just quickly to everyone, as I say, we will do a repeat with Alice when the guidance is out. So later in the year, hopefully you'll see Alice at the Midlands Network Huddle, and you'll also see her at AphA. You know, lots of things for you there. We do have a session next week. We've shoved in an extra session with Philip McManus from Facts and Dimensions. The details are in the magazine and the CEO newsletters that go out. So if you want to link in and join that, I wonder if he's got any Facts and Dimensions on some of these groups. It's all open source data though, mostly. So anyway, thank you all for coming. As I say, the recording will be available on the website in the hub. And if there's no more questions, well, just a thank you very much, Alice, for your time. And that gives everybody 10 minutes back to run off and make a cup of tea before the potential 1 o'clock meeting that they've all got in their diaries, because let's face it, that's the norm. So, or
Thank
just
you
have
very
lunch,
much.
you know, have lunch.
Thanks, Jen. Thanks, Alice.
Okay.
Hope to see you again. Bye-bye.